Hello, ladies and gentlemen. I'm Dr. Mangoi from the Department of Clinical Pharmacology. So I'm going to give a lecture on uh, antiemetics. And this is something that you, as practitioners, I would assume, and I would like to believe that all of you are medical practitioners, maybe currently practicing somewhere as locum doctors or actually in our hospitals. So vomiting is the act, rather the act of vomiting and the sensation of nausea that accompanies it are protective reflexes that serve to rid the stomach and intestine of toxic substance and prevent their further ingestion. So we have got essentially the drugs that we use will target the vomiting center or the chemoreceptor trigger zone. And the toxins as well that cause the emesis itself also target the vomiting center or the chemoreceptor trigger zone. Hence, when we are using our antiemetics, we are using drugs that actually uh, have effect on these two mainly, but also the vestibular center. So we have emetics, the apomorphine, ipecacuanha, powdered mustard suspension, and strong salt solution. And these we use them in some cases of poisoning. And for some that have gone to some of these traditional churches, I know that at some of the churches, for example, ZCC, they have what they call kugaba, and they'll be using a strong coffee like tracker to induce the vomiting. So sometimes you want to get rid for some it's ritual purposes. They want to clean their stomach because they believe or they've been told that there are toxins that are in there. And for some people, it actually works when their stomach problems maybe disappear, or sometimes they because of maybe it's because of the acids and all that. Sometimes it also disappears as well. And we have contraindications to the use of these emetics or these drugs that trigger emesis. For example, when someone has ingested corrosive poisoning, for example, the acids or the alkalis, we don't want to induce vomiting. We should not and we should never induce vomiting. Or also in central nervous system stimulant drugs poisoning, and also kerosene poisoning, and also unconscious patient. Why do we? Why should we not induce uh, emesis in someone who is unconscious? Because they are unconscious, the reflex themselves, if the issues of perspiration and all that, they might happen because this patient is unconscious. So those reflexes also will not or may not be working properly. Also, we don't induce emesis in people who have done morphine or phenothiazine and poisoning. Um, so pathophysiology of emesis. We have the vomiting center or the medulla. Uh, we have got the cerebral cortex, the issues, the smell, the sight, the thoughts. So we call this anticipatory emesis. And anticipatory emesis normally happens, or we normally use a triptan or a phosphotriptan to curb that. Then we have got the cancer chemotherapy, the opioids as well. Then we have got the chemo. These ones they trigger the chemo receptor triggers on, and this is outside the blood-brain barrier. Then we have got the vestibular nuclei, motion sickness. We have got the pharynx and the GIT, chemo and radiotherapy, and gastroenteritis as well. Then the receptors or that are concerned, we have the muscarinic, we have the 5-HT3, this is the serotonin, then the histamine, this is H1, cannabinoid receptor. Then for the chemoreceptor trigger zone, we have got the dopamine, the 5-HT3, the opioid receptors, and the NK1 receptors as well. Then for the vestibular nuclei, we've got the muscarinic and the histaminic uh, receptors. Then for the pharynx and the GIT, we have got the 5-HT3 receptors. And the groups of drugs that are used as antiemetics, we have the serotonin antagonist, the dopamine antagonist, the anticholinergics, the antihistaminics, the cannabinoids, and the neurokinin 1 antagonists. So for the serotonin 5-HT antagonists, these are potent antiemetics, even though the serotonin receptors are present in vomiting center and chemoreceptor trigger zone, the antiemetic action is usually or is restricted to emesis caused by vagal stimulation. And high first pass, they have got high first pass metabolism, hence, some of them we might need to give them via the IV route, still by the liver and the kidney, not dose reduction in renal insufficiency, but needed in hepatic insufficiency, given once or twice daily, orally or intravenously. And the drugs available, so especially rather in our market, the drugs that are available, we have got the ondansetron and palonosetron. We don't have the granisetron and the dolasetron. But because we are training you not to stay here, or we are training you for the future, we also have to mention some of these that we don't have locally. Then the indications: chemotherapy induced nausea and vomiting given 30 minutes before chemotherapy, post-operative and post-radiation nausea and vomiting. So normally when you are seeing a prescription of, or when we see a prescription of palonosetron, normally it's because of the chemotherapy. But for ondansetron, we might see this even in the normal vomiting. Maybe someone has ingested something. We just use the ondansetron as well, just for as an antiemetic. These, they have got an excellent safety profile, but they might also cause headache and constipation. All the three drugs that are on top there, the the first three. Uh, they cause prolongation of the QT interval, but more pronounced with the dolasetron. Then we have the dopamine D2 antagonists. These antagonize the D2 receptors in chemoreceptor trigger zone, and the drugs available with the metoclopramide and the domperidone. But these also we also call them prokinetic agents due to their 5-HT4 agonist activity. And the domperidone, we normally give it orally, rather it's oral. Then the metoclopramide or clopamide, this is via the oral or the IV route. And the metoclopramide crosses the blood-brain barrier, but domperidone does not. So this will also explain their safety, their adverse effect profile, uh, which is better antiemetic, metoclopramide or domperidone. As chemoreceptor triggers on is outside the blood-brain barrier, both have antiemetic effects. And normally we are expecting the same efficacy. But because of the metoclopramide crossing the blood-brain barrier, it has adverse effects like the extrapyramidal side effects. But domperidone is well tolerated. So, given the option, we would choose domperidone because of a better side effect profile. Then the therapeutic uses of clopamine or metoclopramide with the nausea and vomiting that often accompany GI motility symptoms. People who have got hyperacidity, gastroesophageal reflux disease, gastroparesis, way to improve with gastric emptying. Uh, then the diagnostic process, such as intestinal intubation or contrast radiography of the GI tract, postoperative ileus, persistent hiccups. Then we also, as my antiemetics, we also have phenothiazines and butyrophenons. The phenothiazines, prochlorperazine, vertigo with vomiting. And the phenothiazines are antipsychotics with potent antiemetic property due to D2 antagonism in chemoreceptor trigger zone and antihistamine activity. And essentially, we are utilizing the adverse, the side effects or the side gig of these butyrophenols and the phenothiazines because they are also work here. So essentially, these are antipsychotics, typical antipsychotics. Uh, droperidol or haloperidol. These are butyrophenons and are used for post-operative nausea and vomiting, but cause QT prolongation. So when we are giving, when you are considering to give these antiemetics, say your patient has got TB and they are also taking bedaquiline, or they are on an extended dose or an extended treatment of erythromycin or of azithromycin drugs or fexofenadine, drugs that also cause QT prolongation. We have to be careful, or we might then need to avoid using them, or we might just choose to give them palonosorphan, which is a bit safer in terms of that. Then we also have the H1 antihistaminics, effective drugs for motion sickness, anticholinergic, antihistaminic, sedative, and drugs available, meclizine, cyclizine, diphenhydramine, and promethazine, which we also use in pregnancy. Then anticholinergic scopolamine hyoscine used as transdermal patch for motion sickness, but here we also use it orally and also as an injection. Then we have with the cannabinoids, dronabinol used as adjuvant in chemotherapy-induced vomiting. It is a psychoactive substance. Then corticosteroids, corticosteroids have antiemetic properties as well, mechanisms of action, possibly by suppressing peritumoral inflammation and prostaglandin production, used to enhance efficacy of 5-HT3 receptor antagonists in the treatment of chemotherapy-induced vomiting. So you will also see a lot of corticosteroids. I'm sure here maybe in this class we also have people that are going to be oncologists. You prescribe these corticosteroids, the dexamethasone as well, whether it's IV or it's oral, as helping these 5-HT3, for example, normally palonosertran, in the treatment of the chemotherapy-induced vomiting. Also reduce certain side effects of primary antiemetics. Then the benzodiazepines, such as diazepam or lorazepam, are used prior to the initiation of chemotherapy to reduce anticipatory vomiting or vomiting caused by anxiety. Then we have the neurokinin antagonist, apreptant or fosapreptant. We also use it in anticipatory vomiting, according to some literature. But the mechanism of action act as antiemetic, selectively block neurokinin 1 receptor in area posterior. No effect on serotonin, dopamine, or corticoid receptors. Apreptant non-peptide selective neurokinin type 1 receptors antagonists block substance P from binding to the NK1 receptor, broader spectrum and activity in delayed emesis in preclinical studies, augment the antiemetic activity of 5-HT3 receptor antagonists and dexamethasone, inhibit both acute and delayed cisplatin-induced vomiting. Then uses used in combination with 5-HT3 antagonists and corticosteroids for prevention of acute and chronic nausea and vomiting from cancer chemotherapy. The adverse effects, fatigue, dizziness, and diarrhea also might cause enzyme inhibition metabolized by the CYP3A4. So we may inhibit metabolism of many anti-cancer drugs. So with this, we have to take note when you are giving these docetaxel, paclitaxel, etoposide, and vinblastine. We normally want to avoid the apreptant. Metabolism of apreptant may be inhibited by ketoconazole. These are enzyme inhibitors. Then apreptant decrease INR in patients taking warfarin. Yebo. Then therapeutic use of antiemetics, motion sickness, eyes, and vestibular disorders, scenarism, vomiting due to uremia, radiation, and all that. Then vomiting due to pregnancy, vomiting due to pregnancy, vomiting due to cytotoxic and cancer drugs, we use those. Anticipatory vomiting, we use that. Postoperative vomiting, we use that. Then the choice is antiemetics of choice. You can read up. Thank you, ladies and gentlemen.